So today I want to just give you a quick video on the liver, part of just a quick review. And the cirrhosis is the main topic we're going to be talking about. But first I want to just explain to you what the liver does. It functions as a filter. It's a vascular organ. It stores and produces so it acts as storage as well, but it produces procoagulants for vital for hemostasis and blood coagulation. It stores iron. These hepatocytes make bile and secrete it. The sinusoids are the capillaries that are lined with Kupffer cells that carry out waste. Its main job, though, is metabolism of carbs, lipids, and proteins, therefore maintaining a normal glucose level. The liver breaks down glycogen to glucose, so it conjugates bilirubin. So it's a very, albumin's produced in the liver. It's a productive organ. And what happens is, with cirrhosis, is there is a problem with the portal vein. There's a problem with hepatic flow here at the portal vein, coming up from the mesenteric. So what exactly is portal hypertension? It's a derangement of liver cells causing pressure in the portal vein. And you can see this liver is fibrotic. The fibrosis is impinging some of the vasculature, which you can see is causing some of the varices. So you get the fibrosis due to the chronic damage to the hepatocytes. And then because of that, you get the compression of the bile ducts. I drew a nice little gallbladder there. And this leads to the inability or decreased ability to conjugate bilirubin, which leads to jaundice. So it's a progressive thing there. And if you notice the blood flow coming up, that's your portal blood flow here. And the normal flow backs up and causes these esophageal varices. They can cause also bleeding, because you can tell that they look very strained. Ascites, and also they can get hemorrhoids, and same concept. They can bleed and cause problems. So you definitely want to try to keep your patient from straining. They might need a stool softener. But this impedes, this portal hypertension impedes the flow out of the spleen, disrupts the coagulation panel. Often the spleen will get large. You'll have splenomegaly, so then it'll call for more blood flow to the spleen, which makes it bigger, and that further messes up your coagulation panels. The platelets become sticky and they get kind of stuck in the spleen. So there's a couple of different things going on there as far as your blood coagulation. Because you remember, if you remember in the beginning, I said that it produces procoagulants in the liver, and then you've got this spleen problem as well. So what we're talking about are the complications that are related to this. We've talked about the ascites, and those can cause bleeds. It can cause bleeds in your esophagus, and if you were taking care of a patient with a massive bleed in the esophagus, your definitely priority would be airway. That can be pretty life-threatening. So you want to think about that your airway would be your priority. And we talked about the treatments for that. If it's, like a major hemorrhage, they probably would do a balloon tamponade and put them in ICU. There are some other options if it's minor, like they might do the bands. the sclerosing. So just keep that in mind. But like I said, another problem is the ascites. And this is just portal hypertension results in the protein shift that leak into the peritoneal cavity. And as far as treatment, you're gonna make sure you expect the doctor to order someone with a ascites, sodium restriction, 2 grams sodium diet a day. They might give them albumin, diuretics, tolvaptan, TIPS shunt. And again, the TIPS is not always the first option, right? It's after a second, frequent flyer. They could do a paracentesis, aldactone or spironolactone, and rifaximin and neomycin. Those are all some of your collaborative care and treatments for ascites. You want to also consider that when you have this buildup of fluid, you also could get an increase in ammonia levels. You want to think about how are we going to bring down those ammonia levels as well. Lactulose can help. The rifaximin can help. So you want to think about that as well. And what would you see with increased ammonia levels? Well, you probably see change in level of consciousness. You want to, take that into consideration. What else would you see with someone with portal hypertension? Well, you probably would see some edema in the feet and the ankles. You're going to see low total protein, low albumin. So again, you're going to need to make sure that you're going to see some low, like B vitamins, folic acid. So these patients are going to need increased B vitamins when they go home. So if you've ever taken care of someone with ETOH, you know that they get folic acid, they get thiamine. So just keep that in mind. The increased B vitamins, they need a low-fat diet, high calorie, 2 grams sodium. And they're also going to need to weigh themselves because these ascites can just build back up again. Another procedure for ascites is the paracentesis. Make sure they get it, that there's a consent. They need to avoid on call to the OR. They need to be in high Fowlers or sit on the side of the bed for the procedure. And then you're monitoring after the procedure for bleeding because, again, they've got a whole puncture site. You're monitoring fluid and electrolyte imbalance, and you're monitoring signs and symptoms of infection. And fluid imbalance, removing all that fluid could cause hypovolemia. So you're having to monitor your patient, monitor vital signs, looking for those vital signs. You need to know the signs and symptoms of hypovolemia: weak, thready pulse, increased heart rate, decreased blood pressure. And remember, these patients are going to probably be on spironolactone. And why would they need to be on that? Well, spironolactone is a potassium sparing. So keep that in mind. It's potassium sparing, so that would it's also a diuretic, so it'll help get rid of the fluid, but it would also help them keep their potassium levels more normal. You also want to keep in mind with all of these problems, they could have increased hepatic encephalopathy. And that's considered a terminal complication in liver disease. And the characteristic symptom of that, remember, is the asterixis, or the flapping tremors. You want to be familiar with the things that can increase hepatic encephalopathy or precipitate it. And there's a chart in your book. Some of those things are constipation. The actual paracentesis can increase hepatic encephalopathy just because of the removal of the fluid, which can compound the dehydration. Infection can precipitate hepatic encephalopathy, constipation. So there's a GI bleed. There's several things in your book that can precipitate it. You want to make sure you know the labs that you might see with someone with cirrhosis. You're going to see a prolonged prothrombin time, decreased platelets, increased bilirubin. So you want to think about all that. You want to think those coagulation panels will be off. Decreased total protein, increased ammonia levels. So that is all I'm going to talk about with the liver. Again, review your notes. I just want to do a quick video. I didn't want it to be too much over 10 minutes, and just to give you some pointers, and I will see you soon.